ultraviolet radiation is non-ionizing radiation, but it is quite high energy. And when photons of UV light strike the skin surface, they penetrate into the parts of the cell where the nucleic acids are housed. Those incoming photons cause very characteristic lesions in the DNA. These are breakages or changes in the electrochemistry of these base pairs, causing them to do unusual things. And the classic lesions caused by UV radiation are what we call cyclobutane pyrimidine dimers and these TT photoproducts. Very easy to detect in skin that's been exposed to UV light. Now, the key thing is these are repairable lesions. We have DNA polymerases and a very exquisite process can repair this damage. But if that damage is not repaired before the cell divides, then those lesions get converted into mutations and they lead to changes in the DNA sequence and therefore changes in the genetic code. And just to show you what this looks like, these are two photomicrographs of skin sections seen under a microscope. So the top slide here shows skin that's unexposed to ultraviolet radiation, so a biopsy of skin that's been taken when there's been no exposure to the sun. The bottom panel shows a biopsy taken 7 minutes after a burning dose of ultraviolet radiation has been delivered to the skin of a volunteer. And it's been coated with an antibody that can detect specific UVB damage, those DNA lesions that I was talking about in the previous slide, and illustrate those. So these, you can see skin cells here, they light up, showing lots and lots of damage after a very small and brief exposure to the sun. So really just to illustrate the point that this is ubiquitous, this kind of damage. All of us get exposed to the sun every day, and we develop DNA lesions that can be repaired. A question that arises then continually is, well, if we have just a small amount of exposure to the sun, a dose of exposure that doesn't even cause burning or reddening or even a pinkening of the skin, can that lead to DNA damage? Well, summarizing a lot of evidence, yes, it can. A series of experiments have been done by different groups around the world. This is one set of experiments done almost 15 years ago now, in which volunteers were exposed to small amounts of UV, a less than burning dose, over 12 consecutive days. And this is, and they either coated their skin with sunscreen or not, left it unexposed or covered with sunscreen, just as a comparison. So this top line here shows the increasing amount of redness in the skin, increasing amounts of erythema in the skin following consecutive sequential daily doses of small amounts of UV. You can also see changes in the detection of DNA damage there. And then there were two different markers they used, just measuring damage of DNA, thymidine dimers, or P53, which is a gene that's switched on in response to DNA damage. And you can see that in the unprotected skin, that's the skin that didn't have sunscreen at day 5, at day 11, at day 12, there's quite significant amounts of DNA damage as measured by thymidine dimers. There's also significant amounts of cellular stress as measured by P53 when compared with the skin protected by sunscreen. So really just a way of saying that even with small amounts of sun exposure, half a burning dose per day over 11 days, measured on 12 days, you see detectable, measurable, increasing amounts of damage. And there's been quite a few studies like that. When you summarize all of those studies that have looked at suberythemal, small burning doses of, not burning, small doses of UV that don't cause sunburn, the accumulated evidence from human studies says that erythema is not a good measure of damage to skin because you get significant molecular and cellular damage even at doses that are lower than one burning dose. So, you know, this body of evidence is quite substantial and quite persuasive. Now, as I said before, damage to DNA is not life-threatening in itself. It doesn't inevitably lead to cancer. We've developed and evolved very sophisticated DNA repair mechanisms in response to UV damage. We also have other responses. Our skin gets inflamed, and we're used to this from the experience of sunburn. We get reddening and swelling and increased circulation. People also develop a protective tan, that is the synthesis of melanin pigment by melanocytes deposited in the upper layers of the skin, and that provides something of a shield to minimize damage to the nuclei of skin cells. So tanning is an adaptive response to UV, and over time our skin becomes thicker and coarser, and people who are outdoor workers develop a thicker structure to their skin. So there's a range of responses that human skin has evolved and harnesses to protect ourselves from further damage arising from UV exposure. But the key thing I want to talk about today is this DNA repair, because that's really the ability to repair damage that has occurred already. Now, there's several different types of DNA repair mechanisms, and in fact, the more research that is done, the more we understand about these different DNA repair pathways. But the bulk of DNA damage is repaired by this process called nucleotide excision repair, and that's captured in this graphic here. But basically, when there's a damaged base, the DNA denatures, the two strands separate, there's nicks made in the DNA, the damaged portion is excised. We can actually measure that. It can be excreted in the urine. You can actually measure those damaged segments. A new sequence is synthesized from the complementary strand of DNA, and then it's ligated in place. So a very sophisticated repair mechanism. Now, it turns out that those repair mechanisms are not the same in all people. Some people have high capacity for DNA repair. Some people have low capacity for DNA. And this just shows that quite graphically. So this is just a graph showing the rate at which DNA lesions are removed from sunburned skin over time. So this is a graph here showing the amount of DNA damage on the y-axis. It's just a scale for the quantified amount of DNA damage. This is the control baseline unexposed skin. So what we'd expect to see is almost no DNA damage. Then biopsies taken 7 minutes after one burning dose. And these are done, the reason there's a range here is that these are in people with different layers of pigmentation in their skin. So this was a study done in the US. So they had people of white ancestry, Asian ancestry, Latino, Pacific Islander, and people of Black African ancestry. So you can see there's a range of DNA damage on that one exposure to a burning dose. That's not so important for this talk. What I want to really point out is that after 24 hours, passage of 24 hours, only about half of that DNA damage is actually repaired in our skin, so across all skin types. And even going out to 7 days after that one small burning dose exposure, there's still detectable, measurable, leftover residual DNA damage still sitting in those skin cells. So this is really just a long-winded way of saying DNA damage is not universally repaired. Even though we have very good DNA repair mechanisms, not all DNA damage is repaired even a week after one small episode of sun exposure. So when you multiply that up over frequent daily exposures in the tropical sun, for skin that may not be well adapted to sun exposure, you can imagine that this can accrue over time and lead to a lot of unrepaired DNA damage in skin cells. I mentioned before that we have across populations differences in DNA repair. But DNA repair is actually governed at a molecular level. It's governed at a cellular level. It's even down to the strand of DNA. So cells prioritize the repair of DNA for cells that are about to actively divide. So if a cell is in the stage of preparing to undergo mitosis, then the cell will invest a lot of energy in putting out DNA polymerases to repair that damaged DNA. But cells that are quiescent or dormant may have actually just gone to sleep, and so the DNA damage will sit there, and if they have to suddenly switch on, they may not have time to repair DNA damage. So stage of the cell cycle determines rate of DNA repair. Some genes that are actively being transcribed all the time are prioritized by cells to repair their DNA. And as I said, it's the strand of DNA, the strand that is actually undergoing active transcription is prioritized for repair. So it's a long way of saying that some DNA repair occurs very rapidly, great fidelity, and great precision. Other DNA repair happens much more slowly. And that can be a problem if that cell needs to divide rapidly later on. So there's high variation in DNA repair across cell types. And as I said before, if that DNA repair does not occur before a cell undergoes cell division, then what happens is there becomes a permanent error in the code of that DNA. We call that a mutation. When the sequence of the genetic code has been changed because the lesion has not been repaired, it means that a new base is substituted in the DNA sequence. That's a mutation. Now, a mutation in one gene, in one cell, is highly unlikely to lead to cancer because most cancers require knockouts of multiple genes. But once a gene has a first mutation, it's very likely to be susceptible to further events. It might be slower to repair its DNA damage, can acquire a second mutation, more sun exposure, can get a third mutation, and then go on and get a fourth or fifth or sixth mutation. This is when you start to see microscopic changes in the appearance of the cell, antipia, dysplasia, and can be neoplasia. This leads on to malignancy. So it's a stepwise process, can take decades, but it can be much quicker if a person has lots of sun exposure or poor DNA repair or immune compromised. All of these kinds of things can accelerate the acquisition of mutations. And we see this spectrum of DNA damage in cancer. This is a paper that I've taken the picture, the graph here from. It's almost 10 years old now. What this graph displays is the mutation burden. That is, how many mutations are there per unit length of DNA in a whole range of different cancers, from very rare childhood cancers down at this end of the scale, through to breast cancer and pancreatic cancer in the mid-scale, up to these rapidly growing, quite malignant cancers, esophageal cancers, bladder cancers, lung cancers. And at the very far end of this scale is melanoma. And what you can see plotted on this logarithmic scale here, as I said, is the amount of DNA damage. You can see that these cancers up the far end, and particularly melanoma, have very high DNA mutation burdens. Melanoma has rates of DNA mutations that are as high or higher than any other cancers, even these cancers caused by the hazards of smoking. So these UV-specific mutations, and we can see that because of the pattern of DNA mutations as shown in the color graph at the bottom. The yellow shows very high levels of UV-specific mutations. So melanomas have really high mutation burdens, and it's almost all due to the effects of sunlight, solar ultraviolet radiation. What's become apparent in the last couple of years is that we actually see high mutation burdens in normal or outwardly normal appearing human skin. So this paper that I'm showing you here from 6 or 7 years ago now caused quite a sensation. So what this experiment was, or what this paper was about, was that they looked at the rate of UV-specific mutations in sections of normal appearing human skin. So these are eyelid specimens taken from blepharotomies, plastic surgery procedure to tighten up eyelids when they've become droopy, basically, to use a turn of phrase. So these were taken predominantly from female patients in the north of England, so not a very sunny place at all. The patients in the study were, some were European heritage, but some were South Asian heritage from Indian ancestry. So small number of people took these eyelid samples, and you can see they've sectioned them very carefully and then taken biopsies, very discrete punch biopsies. Then from each of those biopsies, they've sequenced the DNA of the cells in those eyelids. And I have to keep repeating, these were just normal appearing eyelids. They weren't taken from the patients because they were sun damaged or had skin cancer. They were perfectly normal looking skin. And so when they sequenced the cells from these eyelids, they found quite high levels of the C to T mutations, these characteristic sunlight-caused mutations in this normal skin. And they saw them at rates that were almost the same as you see for cutaneous squamous cell cancers or cutaneous basal cell cancers or for melanoma. This striking pattern of sun damage, even in normal appearing eyelids from patients living in the north of England. And further, when they actually then sequenced clones of cells, they found that there were specific mutations in these high-risk genes here. So I won't go into the details, but these are all genes that cover very specific growth properties of cells or repair properties or stress properties of cells. We consider these genes to be driver mutations for skin cancer. What these researchers showed was that these are common mutations found in clones of cells taken from eyelids. So this is a long way of saying sun damage is highly prevalent in human skin, particularly in fair human skin, in lightly pigmented human skin. And a lot of skin cells are quite a long way down the pathway towards getting skin cancer. So had these patients had just a little bit more sun exposure, one would think that many of these might have turned into cancers, which is what we see in Australian patients and in Queensland patients, very high burdens of skin cancer and a small proportion of patients. So I've talked to you so far about DNA damage that occurs as a result of exposure to the sun. I've talked about the rate of DNA repair. I've talked about some of the protective mechanisms. And so what we've known for a long time in epidemiology and in clinical medicine is that skin cancer occurs unequally in different populations around the world. We know that there's great variation in human populations, so that in people with skin types 4 or 5, so moderately to darkly pigmented skin, suffer much less DNA damage, much fewer skin cancers, and have fewer adverse effects from high levels of sun exposure. People with skin types 3 or even 2 and 1 with very light skin that doesn't tan at all. So I don't have a picture of skin type 1 or 2, but those people are very fair and they burn upon exposure to the sun. We know that these phenotypes have very high rates of skin cancer and high rates of DNA damage. And all of these phenotypes are determined by genes, by a person's genetic makeup. So these are data from a study that we're running here in Queensland called QSkin, from about 18,000 people for whom we have DNA samples. We also have a long-term follow-up on the rates of skin cancer. This graph here at the top just simply shows you the distribution of genetic risk for skin cancer, for melanoma specifically in this population, based on an instrument that collates information across 45 genes. So you can see it's almost a normal distribution. Some people up here have very high genetic risk of skin cancer. Some people have low genetic risk. And we know that this instrument works extremely well because when you look at the rate of skin cancer in these different deciles, so these are 10 equal-sized groups of people based on very low risk, moderate risk, high genetic risk, you can see their rates of skin cancer go up in a linear fashion as the genetic risk goes up. And these genes predominantly are genes that code for skin pigmentation, not exclusively, some of them code for DNA repair as well, but skin pigmentation is a key driver. Now, I was hoping to show Qatar-specific information on genetic risk for skin cancer. I haven't been able to find any, but there is some fantastic research coming out of the Qatar Biobank. So this was a study published just very, very recently. First of all, just looking at the genetic structure of the population in Qatar, and you'll know this much better than me, but there are quite a number of distinct ancestry profiles in this population. People of African heritage, people of Persian heritage, people of South Asian heritage, and admixture across all of those groups. Why that's potentially important, and that's what this study here was looking at, was how does that predict your future risk of cancer, and how well do those instruments, those polygenic risk scores, predict cancer in these different ancestry profiles in the Qatar population. And so you can see this is an instrument for prostate cancer, so nothing to do with skin cancer, nothing to do with UV, but just making the point that in heterogeneous populations, rates and risks of skin cancer vary based on genetic background. So I'd be very, very confident to say that you would see striking differences in skin cancer risk as well in the Qatar population based on population ancestry. So I'm going to reach out to the Qatar Biobank. Some of those people may even be on this call, but that would be very interesting to see if there was any work done on polygenic risk scores for melanoma. So I'm coming to the very end of my talk. This is my last, second last slide now. So my first question that I posed to you was how much sun exposure is needed to cause skin cancer? I've talked for 25 minutes and I've given you a very unclear answer because there's no one size fits all. It varies very much. It varies depending on your genotype. It varies depending on your phenotype. It varies depending on the cells that are being exposed to the sun. It varies, I haven't talked about this, it varies according to your age. What we do know is that we can measure the effects of sun exposure in the skin every time a person goes out. Even for people with dark skin types, there is some damage, but the good news is that almost all of that damage is repaired time, but not all of it. And unrepaired damage that stays in skin cells can in the future lead to skin cancer. So I'll close out there. This is an image of the city of Brisbane where we're based now, although it's raining at the moment. And I'm going to hand back to my colleague, Rachel Neal, who will be talking to you about some of the challenges in advocating sun exposure for health. So I'll stop sharing the screen.
Dr. David, are you okay to take some questions while we're switching presenters? David, can you hear us? I think you've muted your microphone.
I don't think he's hearing us.
David, can you hear us? Your microphone is muted, David.
I think, yeah, he's muted.
Okay. Rachel, should we move on to your presentation?
Can you hear me okay?
Yes.
Yes.
Okay, let me just share my screen.
Sorry, Rachel, there's some feedback on your microphone.
I don't know how to fix that.
Did you switch devices in between the start of the presentation?
No, I haven't touched it.
Okay.
Let me just, hang on. How's that? Is that any better?
No. Sorry, while we're trying to fix the audio with Rachel, David, are you okay to take a few questions?
Yes, I am. I'm sorry that I'm not sure what's going on here, but maybe it's the transition across 8 time zones.
No problem. No problem. Dr. Ghadir, would you like to put the questions forward?
Yes, yes. Thank you, Dr. David, for the very rich and informative presentation. We have some questions from the audience. I know you had that about risk factors or determinants for the DNA repair. Can we sum up for the audience what could be those the determinants for DNA repair and, you know, on different levels, the genetic makeup, maybe the lifestyle and the behavior? Please go ahead.
So look, that's a very good question. I should have probably spoken about that. I hope you can hear me. So for melanoma specifically, the key, and we break the risk factors into environmental and host. The environmental risk factor, the key environmental risk factor for melanoma is sun exposure, sunlight, and UV exposure. The host factors are fair skin type that burns and does not tan, when people have a high burden of melanocytic nevi on the skin or common moles. We know that people with red hair, freckles, so that they carry a polymorphism, a variant in the MC1R gene, so that confers an increased risk. Family history confers an increased risk of melanoma as well. For the other kinds of skin cancers, particularly the squamous cell skin cancers, we can add to that immune suppression, whether that's from pharmacologically mediated through organ transplant or HIV or other immunosuppression. And also smoking is a risk factor for SCCs of the skin.
Okay, thank you. Thank you. There is another question here. Maybe we should leave this for Dr. Rachel, or we can say it now. The attendee is saying that you mentioned that sunscreen can help protect the skin and DNA damage. Can you please elaborate on the significance of the SPF factor here? And is there, or are there different types of UV radiation that may be more harmful than others?
Yes, so the first question about sunscreen, in general, yes, sunscreen protects the skin from the DNA damage that is incurred by UV exposure. There are different kinds of sunscreens. There are organic sunscreens and physical sunscreens. They work either by absorbing the radiation or deflecting it and scattering it. That mechanism doesn't really matter so much, but there's good evidence. There's about 7, 8, 9, 10 studies that have been done in which sunscreen, when it's applied at the correct dose on the skin, provides almost complete protection from the DNA damage caused by UV, even at quite high doses of UV. So it certainly does work.
Okay, thank you. There is another question, I believe, about the situation in Australia. So the attendee is saying that the rates of skin cancer is quite high. What could be the reasons or the risk factors for this? Is it the UV light, genetic? Is it the increased amount of sun exposure?
It's all three of those things. So the risk of skin cancer in Australia is predominantly restricted to people of European ancestry. Many Australians have European ancestry, but by no means all. So this is largely from Northern Europe, from England, Scotland, Ireland, and Wales. So people with very fair skin types in the 1800s came out to Australia, a subtropical and tropical environment for which their skins were poorly adapted. So you've got people with a susceptible phenotype living in an environment in which there's generally warm weather, pursuing lifestyles or behaviors where they're not covered up against the sun. So, and also having genetic susceptibility. So it's a conglomeration of 3 or 4 different drivers, all contributing to very high rates of skin cancer in this one population.
Yeah, thank you. Do we have more time for the other question?
Rachel is actually here now in my office. So Rachel, do you want to give a talk?
Yeah, I'm going to give you to avoid the feedback.
Okay, let's pull that up here.
Sure.
One more question, Dr. David, the last question from the attendees, please. So
Yes.
what could be your advice regarding, recognizing the symptoms of skin cancer, the early symptoms? How?
The early symptoms. Yeah, so of the 2 main kinds, melanoma and non-melanoma. For melanoma, people will often see a small dark lesion on their skin that is changing or growing rapidly or has an asymmetrical appearance. So it's to do with a changing dark pigmented lesion on the skin. For the non-melanoma skin cancers, it will often be a reddened erythematous or scaling lesion that is not healing and may bleed or itch or cause pain. But basically a non-healing macule or papule or nodule on the skin would be concerning and would lead to medical intervention. So I
Thank
have
you.
Rachel next here. So Rachel.
I think, Dr. Ghadir, that there will be an opportunity for further questions at the end of the session. So I think Dr. Rachel will begin her presentation now, and we'll keep the remaining questions for the end of the session.
Okay.
Hi, everybody. It's a pleasure to be here. I'm assuming you can all hear and see me okay.
Yes, thank you.
Right. So today I'm going to talk to you about the health benefits of vitamin D. That there've been over 100 different health conditions that have been associated with vitamin D. I'm going to talk about a few of them, and then we'll talk about some other things at the end. So here's an overview of my talk. The health outcomes that I'm going to talk about are bone mineral density and fractures, because we know that that's really important. Then I'm going to talk about the health outcomes that have been the primary outcomes for several large trials. I'm going to talk about prevalence of vitamin D deficiency and then how we maintain vitamin D through sun exposure. So before I get into talking about those health outcomes, I just want to give you an overview of the 5 trials that have been conducted that have had more than 5,000 participants. So they are ordered on the screen from the older trials to the newer trials. So the WHI, the Women's Health Initiative trial, and the record studies both began in the 1990s. WHI randomized over 36,000 people and record about 5,000. Importantly, they both used what would now be considered to be a fairly moderate dose of vitamin D at 400 and 800 international units per day, respectively. And both of them had fracture as their primary outcome. Recently, there have been several other large trials conducted. The VITA trial in New Zealand, VITAL in the United States, and D-Health in Australia, which is the trial that I'm the lead investigator for. The VITA trial and D-Health both used a monthly dose of vitamin D at 100,000 and 60,000, whereas VITAL used a daily dose. And VITAL also used omega-3 fatty acids in a factorial design. For VITA and VITAL, both had cardiovascular disease as a primary outcome, and VITAL also included cancer, and D-Health had all-cause mortality. One thing to note is that the lower 25-hydroxy-D concentrations, that's the marker of vitamin D status, I'm sure you're all aware of that, in the older trials compared with the new trials. Now, this may reflect differences in country or differences in the temporal change over time, but it's more likely to be driven by changes in 25-hydroxy-D testing. We know that historically the assays have been extremely problematic. These have now improved, and we've been using the gold standard LCMS assays, which tend to measure a bit higher. Just a flag that the vitamin D health studies have identical baseline 25-hydroxy-D concentrations and the proportion of people with a baseline level of less than 50 nanomoles per litre. So these trials collectively underpin a large amount of what we see in the meta-analysis. So starting with bone mineral density, I don't expect you to take in this forest plot, but just to note, this shows the weighted mean percent difference in the lumbar spine bone mineral density. And you can see that there's a tiny difference. It's 0.25% difference in the bone mineral density in the lumbar spine in this meta-analysis. And what they found was that the effect estimate between the futility boundary was 0.5% for total hip, forearm, and total body, and 1% for lumbar spine and femoral neck. So that basically says that we've got pretty reliable evidence that vitamin D does not alter bone mineral density by these amounts or more. And the VITAL study and a sub-study, an ancillary study of that very large study, confirmed that effect. Importantly, the study conducted in Calgary found that high doses of vitamin D, 4,000 or 10,000 international units per day, might actually decrease bone mineral density. So we need to be cautious about using these high doses. When we look at fractures, which obviously is important, bone mineral density is only an issue because it increases our risk of osteomalacia, which causes pain or fracture. So there have been 19 systematic reviews and meta-analyses of vitamin D and fracture, so a lot of reviews of this. And an umbrella review found that there was no evidence of benefit of vitamin D supplementation alone, and indeed there was possible harm, particularly intermittent large annual doses. Another way of getting a handle on what might be important is to use, in addition to trials, is to use Mendelian randomization. And most of you have probably come across this, but just in case you haven't, an overview is that in Mendelian randomization, at birth, we have random segregation of the alleles of influence and exposure. So this is kind of like randomizing people to an exposure in a trial. And what it does is when we use the sort of genetic prediction of exposure, we're essentially equaling out the confounders between exposed and our control groups so that we can do a comparison between groups that's more reliable than a typical observational study. So when we look at the Mendelian randomization studies for vitamin D and bone mineral density or fractures, we see that there's very little support from the MR studies for an effect of either of genetically determined vitamin D. So on the left, you see the change in bone mineral density per 1 standard deviation increase in genetically determined 25-hydroxy-D for forearm, femoral neck, and lumbar spine bone mineral density using various different approaches to the analysis. But you can see for all of them, the confidence intervals are crossing the null, and there's very little support for that. When you have a look at the plot on the right, you can see that this is looking at, it's a different approach. It's not a typical MR approach, and it's per 1 increase in a vitamin D allele score. And again, you see for the most part, very little evidence for a benefit of vitamin D on fractures. So in terms of the conclusions for bone mineral density studies, the results from most of the large RCTs and supported by the MR studies in generally healthy populations indicate that taking a vitamin D supplement doesn't influence bone health, and that very high bolus doses may actually have deleterious effects. Whether monthly dosing is harmful is a bit unclear. We're literally about to push the button on the D health fracture analysis with 1,171 events where we used a monthly dose. So this will clarify whether or not this may be harmful. Really importantly, these findings may not be generalizable to people with severe vitamin D deficiency or osteoporosis and in older adults living in residential communities. And I can talk about that a bit more. But I think that the advice I would give that it's important to avoid deficiency, but advice to maintain 75 nanomoles per litre, which we see coming out of some organisations, doesn't appear to be justified. And in the interest of time, I haven't gone into all the subgroup analyses, but even in the VITAL trial, when they analysed the data according to people who had low 25-hydroxy-D at baseline, there did not seem to be any benefit of supplementation. So deficiency, avoiding being less than 50 nanomoles per litre is probably a good idea, but I don't think there's evidence that we need to go higher than that. I'm happy to talk about that more in question time. Just a note about vitamin D and calcium, that the systematic reviews and meta-analysis suggested there may be some benefit of co-supplementation, but the studies have been poor quality. And importantly, again, no benefit in studies restricted to people dwelling in the community. So some evidence for people in aged care facilities. Turning now to all-cause mortality. D-Health is the only trial where all-cause mortality was the primary outcome, a high number of deaths, so a well-powered analysis, and no evidence of benefit for all-cause mortality. The figure shows in pink vitamin D and blue placebo the cumulative incidence over time. The hazard ratio was 1.04. VITAL and VITAD both also found no benefit for all-cause mortality, but RECORD and WI, albeit with the upper bound of the confidence interval, including the null, they did find some evidence of benefit, but note that both of these also used calcium. When we look at the meta-analysis, we see that for daily dosing at the top, there is some benefit, a relative risk of 0.93, whereas for bolus dosing, there was not a significant benefit with a relative risk of 0.98. But when you take out those studies that used calcium also, we see no evidence of benefit of daily dosing at all. In terms of the Mendelian randomization studies, overall, there is no effect. This is the latest study done, and you can see an effect of 0.99. But when they had a look at what happened when they looked at the change in 25-hydroxy-D concentration within subgroups, they found that in people who had a level of less than 50, going from a low level to a high level, did actually show some benefit. So again, this supports my contention that we need to avoid levels of less than 50, but supplementing people higher than that is not of benefit, recognising that both D-Health and VITAL had most people at 75 or higher than 50% of people at that high level. Turning now to cardiovascular disease incidence, this was the primary outcome for both VITAL and VIDA. and neither study found any benefit of supplementing a largely repeat population. Again, moving people, the mean level in the population did not seem to be of benefit for cardiovascular disease in either of these studies. And this is confirmed by meta-analyses of both stroke and myocardial infarction, which found no benefit at all. However, again, the Mendelian randomization studies suggest that a level of less than 50 and particularly of less than 25 is where we may see some evidence of a link between 25-hydroxy-D, genetically determined 25-hydroxy-D, and cardiovascular disease. Looking at cancer, this is where we start to find some really interesting things going on. For cancer incidence, there is no benefit in VITAL, which is where the only study with this as a primary outcome. In the meta-analysis, this was also supported, but in the meta-analysis largely driven by VITAL, so it's important to note that there did seem to be benefit in people who had a BMI prior to supplementation in the normal range. And in these people, we would expect a greater response to supplementation. So that might well explain why this happens. And we'll take a look at this in D-Health to see what we see there. For mortality, it gets really interesting. So in VITAL, there wasn't an overall significant effect of mortality, although a 17% reduction in the hazard ratio. But when they did an analysis excluding the first year and the first 2 years, there was a marked and significant reduction in cancer mortality. And you can see that from the separation in the curves that accrued over time. In D-Health, however, we found the opposite. Overall, we found a 15% increase in the hazard ratio for cancer mortality and a separation of the curves over time. So again, blue, placebo is blue and pink is vitamin D. The curve on the right shows how the hazard ratio varies with time. And when we excluded the first year and the first 2 years, particularly the first 2 years, we found a marked and significant increase in cancer mortality in the vitamin D group compared with the placebo group. Looking at the meta-analysis, again, split into daily supplementation and bolus dose supplementation, you can see that daily dosing seemed to be beneficial, whereas bolus dosing did not. And if anything, we would contend that it may be harmful, although not significant overall. The MR studies show no overall effect of vitamin D supplementation, perhaps some benefit in people who are vitamin D deficient at baseline. So the implications of this: population-wide supplementation is unlikely to be of significant benefit in countries where, unless there's a really high prevalence of vitamin D deficiency. So if it's being used to manage a high prevalence of deficiency, then something like food fortification may be appropriate. But otherwise, shifting a repeat population like Australia or the US to be even higher doesn't seem to help. It's possible that supplementing patients with cancer to prevent cancer mortality may be appropriate, but we actually don't know whether supplementing the patients is important or whether or not supplementing people before they get the cancer changes something like the stage of cancer, and therefore it's this sort of longer term supplementation that may be important. So we need to look at that further. Clinical and public health policy should focus on ensuring populations of vitamin D replete, and I would argue that 50 nanomoles per litre is an appropriate cutoff to use. And while the effects of bolus versus daily dosing are not completely clear, I would adopt a precautionary principle and use daily dosing because of potential harms for bone health and for cancer mortality. And there's also some emerging evidence that suggests that vitamin D daily dosing may be beneficial for infectious disease outcomes, but bolus dosing may not be. And obviously in an environment where we have a pandemic situation, then that would also be important to consider. I'm now going to talk briefly about the prevalence of vitamin D deficiency. This shows a map around the world with the colours, the countries coded according to the portion of the population with a level of less than 50 nanomoles per litre. So you can see in Australia that it's less than 25, and it's actually about 23% overall. In the US, it's 25 to 49%. And you can see in the country there, the little tiny green blip, where it's 50 to 74% of people who have a level of less than 50 nanomoles per litre, noting that the assay that was used for this study was potentially measuring low, so it might not be quite as bad as it looks. So this is the study. It comes from a study published in 2019 with the analysis done in 102,342 medical records collected from the Primary Healthcare Corporation, which I'm sure you're all aware about, aged 18 to 65. And so you can see that vitamin D deficiency has been classified into less than 25 nanomoles per litre, 25 to 49, and 50 to 74, with the blue in people who had no evidence of pre-testing vitamin D therapy, and the orange people who had received vitamin D therapy prior to the last test. So looking at vitamin D deficiency, that's 25 to 49 nanomoles per litre. Actually, that's not quite right. It's less than 50 nanomoles per litre, so it's capturing it all together. It's 71% of people vitamin D deficient, according to that cut point, in people who had not been previously supplemented, and 14% of people overall had severe vitamin D deficiency, classified as less than 25. And I don't think we need to be using a level of 75, but if you use that, then the vast majority of the population would be considered vitamin D deficient, even among people who had received vitamin D therapy prior to their last test. I noticed that someone had asked for some information about vitamin D deficiency in adolescents and children. I could only find an older study about that from a study done in 2007 with a total of 458 children. And you can see here, this shows the percent of 25-hydroxy-D, less than 50 nanomoles per litre was about 10% in younger children, 30% in people 5 to 10 years, and just over 60% in adolescents aged 11 to 16 years. As to why that might be, it's probably changing in behaviour and changing clothing, etc., in that age range. Finally, if you don't want to use a supplement and people want to maintain their vitamin D through sun exposure, well, how do we do that? I'm just going to show you one figure. This is some modelling that Thomas Elliott here at QMR Berghofer and Louisa Gordon have done for us. And this shows how much time you would need to spend outdoors in minutes per day for Brisbane. And the reason I'm showing you Brisbane is because the latitude of Brisbane is very, very similar to the latitude of Qatar. So this shows how much is needed for people with type 1 to 4 skin, Fitzpatrick skin type, if they're exposing 35% of their body surface area. So that's basically wearing shorts and a short-sleeved shirt, and they were out for 4 days per week. So you can see in January between 7 and 8 a.m. you would need 10 to less than 20 minutes. In the middle of winter, if you went out at that time, you couldn't make sufficient vitamin D, even in Brisbane. It would take more than 60 minutes. But important to note that in summer, provided you're out between 8 a.m. and 4 p.m., it's less than 5 minutes per day in shorts and a t-shirt that would be enough to maintain adequate vitamin D levels, so long as you weren't deficient to start with. In the middle of winter, in the middle of summer, in the middle of the day, we can still be out for a really short time, about 10 minutes. But importantly, early morning or late afternoon exposure is not sufficient in winter, and even in summer, it's a bit of a problem. So for those of us who go for an early morning walk and then arrive in the office and don't go out again and leave later in the day, it's very difficult to maintain adequate vitamin D levels. Certainly in southern states in Australia in winter, it's very, very hard in winter, because even though there's enough, you can get it with only about half an hour outside, it's very hard to expose enough skin because it's too cold. So that's where I'm going to leave it today, and I'll be very happy to take any questions. Let me stop the share one.
Thank you, Dr. Isabel. Sorry. So we have time for the questions in the chat box. Let me. We're having 3 questions for Dr. Rachel. The first one about, are there any cautions or contraindicators of using high-dose vitamin D supplementation?
Yes, I would argue that yes, there is. We can see that if you're using a dose of 10,000 IU per day, we do see an increased risk of poor bone mineral density. Big bolus doses, so giving intermittent doses, increases the risk of fractures. That's been shown in a couple of studies. And in fact, in D-Health, we found that a dose of 60,000 international units per day in people who had a normal body weight at baseline caused an increased risk of falling, and then we've seen that potential increased risk of cancer mortality. So I would aim to use a modest daily dose. 1,000 international units per day in almost everybody is sufficient to avoid a 25-hydroxy-D level of less than 50 nanomoles per litre.
The other question, what supplements, I think, Mr. Mahdi, this is what he meant, are known to have reduced vitamin D levels. What are the specific risks of low vitamin D levels in pediatric population?
In a pediatric population, having vitamin D deficiency has been shown to, obviously it's a problem for bone mineral density. We need to ensure that we don't cause rickets. So, but you have to have actually really low levels to cause rickets, like less than about 15 nanomoles per litre. So that's important. But also there is some evidence, although it's not solid, that vitamin D deficiency in the pediatric population can increase the risk of allergies and subsequent autoimmune diseases. And vitamin D seems to be playing, and sun exposure separately from vitamin D seems to play an important role in multiple sclerosis. So having adequate sun exposure through the life course is probably as important as vitamin D, in fact, for MS.
Last question. Any difference in effectiveness between using D2 and D3 as supplements?
Yes, there is. The evidence suggests that it's much better to use D3 as a supplement than D2. So these days, the trials very rarely use D2 because it has shown to be less effective than D3.
One more question, please. What could be a dietary advice to supplement vitamin D level? Dietary advice. Yes.
Obtaining sufficient vitamin D through diet is extremely difficult. There are not very many good food sources. Oily fish is the best food source. You can get some vitamin D from other animal products like red meat and eggs, but otherwise it's very difficult. So what we see when we look across the world is that most people only get between 100 and 200 international units of vitamin D per day from the diet. And so if you're not getting adequate sun exposure, like sun exposure is the best thing to do because you don't need to be out for very long, so long as you have adequate skin exposed. And you also get the potential other benefits of sun exposure. There's emerging benefits for our immune system particularly, but also for things like release of nitric oxide from the skin, which may have benefits for things like blood pressure. So I would advise modest, and I mean 5 minutes, plenty of skin exposure, sun exposure. If that's not possible, then a supplement is much better than trying to maintain vitamin D through diet.
Thank you so much, Dr. Rachel. Thank you, everyone, for this very interesting discussion. And really very interesting also and important questions have been directed from our attendees. I will leave the wrap up. Thank you for our speakers. We really appreciate the informative presentation you have delivered. And the wrapping for this session, I will leave this to Dr. Zak, please, Dr. Zakaria.
Yeah, thank you very much once again, Dr. Rachel and Dr. David. Thank you for joining us. Your time and your efforts are really appreciated, and thank you for taking the questions as well.
Yes.
Also, thank you, Dr. Ghadir, for moderating today's session.
Thank you.
Our next event will be on Sunday. We're having a face-to-face workshop that will be hosted in the Itqan Simulation Center that was looking at managing infectious diseases during mass gatherings. So we look forward to welcoming everybody to that event. Thank you, Dr. Rachel and Dr. David, once again, and we look forward to inviting you again to our CPD program. Thank you very much, everybody.
Thank you very much for the opportunity.
Thank you. Bye-bye.
Bye-bye. Thanks.